Hi, everyone. Welcome back to the EndoSmilePodcast. Thank you so much for tuning in. I hope you all enjoyed video one. We're going to keep that momentum going moving forward in video two. My name is Kisa Iqbal. I'm a general dentist, and I'm particularly interested in the field of endodontics. And so the whole point of this channel is to allow us to get a good discussion going and really explore one avenue of endodontics. So let's dive right in. Today's topic is about CBCT, and it's titled The Use of CBCT in Endodontics. And so the focus is going to be around the 2015-2016 joint statement by the AAE and the AAOMR about the use of CBCT in endodontics specifically. So this is a screenshot of that statement. I'm going to go ahead and get my cursor ready. And so AAE stands for the American Association of Endodontics, and AAOMR stands for the American Academy of Oral and Maxillofacial Radiology. And so the whole purpose of this statement was to provide scientifically based guidance to clinicians regarding the use of CBCT in endodontics. And so in the statement, they go through different recommendations, and what I did is I wanted to kind of condense it and make it more digestible. So let's go ahead and get started. A quick disclaimer, I wanted to include a picture of a compass here because this statement is supposed to be used as a guide. It's by no means a way to replace clinicians' judgment. Definitely every patient in every case should be considered thoroughly and independently and be treated on a case-by-case basis. We know that radiography is essential for diagnosis, treatment, evaluation, and assessment. And lastly, CBCT should not be used for the purposes of screening. So let's go ahead and explore some basics. So a CBCT can be categorized into three, one being large, medium, and limited. And this category is based on the specific field of view. So throughout this presentation, I'm going to abbreviate it to FOV. CBCT stands for Cone Beam Computed Tomography. And so that's the acronym that I'm going to use. And we know that for most endodontic applications, we want to focus in on limited field of view CBCT. And I think this panel does a great job differentiating the three types. So in panel A, we see a large CBCT, and what it does, it basically scans a large area of the craniofacial skeleton and can be used for actually cephalometric analysis. In the medium CBCT, it focuses in on the maxilla and the mandible. And like I said, what we're interested in is the limited field of view, which focuses in on a specific area. And that provides different advantages, one of which being that it provides less radiation dose to the patient. Secondly, it provides a higher spatial resolution. So the fact that we're targeting a smaller area, the result is that the resolution is higher in the imaging. And thirdly, it provides shorter volumes to be interpreted. So this is just a quick snapshot of the three different views that can be used. So we have the axial view, the coronal view, and the sagittal view. And obviously all these views can be seen and basically used as little puzzle pieces to get a better idea of what's going on in 3D and hopefully be used as a tool moving forward. So let's go ahead and get into some of the details in terms of the recommendations. So in the first recommendation, they do say that intraoral radiographs are the imaging of choice. However, in limited field of view CBCT, it can be used for the diagnosis in patients with contradictory and non-specific clinical signs and symptoms. So for example, in an untreated tooth where there's non-specific signs and symptoms, or in a previously treated root canal, seeing CBCT can give further information about what's going on. And I think this image does a great job highlighting some of these points. So in panel A, we see the conventional periapical radiograph around tooth number 31. We can see that there's definitely a radiolucency noted around the bone here and also specifically near the apex. But when this tooth when this patient underwent a CBCT scan, we could really appreciate the extent of how large this radiolucency really is and how extensive it is. And we see that in the view here and also in the axial view here. And I think what is a great point to mention, what this image highlights, is that of course, as endodontists, we want to focus on the tooth, but also when we feel that there might be an appropriate referral necessary, we should go ahead and do that. So if you take a CBCT and you suspect some type of cyst or some pathology or something else going on, definitely as healthcare providers, we can make appropriate referrals, whether that be to an oral surgeon or discussing a case with colleagues to get a better understanding of what's really going on. Sometimes the lesion might not be endodontic in nature, and so the appropriate specialist and referral might be warranted. All right, the rationale behind recommendation 1 and 2 is that a CBCT can actually detect periapical pathosis before a 2D image. And in one of the studies that they cited, the primary endodontic diagnosis was detected in 20% of patients using intraoral x-rays versus 48% using CBCT. And I think that highlights how useful it can be used, how useful CBCT can be used in detection. Here, I thought this was very important. In cases where there's persistent intraoral pain after root canal treatment, it can often become a diagnostic challenge, such as an atypical odontalgia. And this is a picture I got from a study in which a patient had undergone root canal therapy on tooth number 3, and even though in the periapical image it's not quite obvious what's really going on, when a CBCT was taken, it was clear that there was bone loss. And what that highlights is that a CBCT can detect, in one study, 17% more teeth with periapical bone loss rather than that conventional radiography, which I think is very important. All right, so the use of CBCT in initial treatment can be used when dealing with teeth that have extra canals, complex morphology, and dental anomalies. So in teeth that are notorious for having complex morphology, such as mandibular first premolars, mandibular second premolars, sometimes they have very, very complex morphologies, and I think this highlights that very well. So here in this image, we see that there's one canal. In this image here, the canal breaks up and kind of joins back in at the apex here. In this image, there's one canal, and then toward the apical aspect, it looks like it branches off and might crisscross again towards the apical third. Here in this image, it branches off and kind of joins back in and makes joins to make that one apical foramen. And in this last image here, we see two separate canals with two separate foramen. And CBCT is a great way to give you a better understanding of what to expect before you even start, so you know what's going on. It can also be used mid-treatment if you're stuck. It can give you a better idea of what's going on and help you moving forward. In the fourth recommendation, we see that it can be used intra-appointment to identify and localize calcified canals, and it can also be used for post-op imaging. So the rationale behind those recommendations is that in 2D imaging, it doesn't always consistently reveal the actual number of roots and canals, like I showed in the previous example. Specifically, a study was done in 2013, and they found that CBCT showed a higher mean values of specificity and sensitivity in detecting MB2 canals compared to intraoral imaging. So this is an image that shows first maxillary molar and second maxillary molar. So we know studies show that maxillary first molars 96% of the time have an MB2 canal, and also actually maxillary second molars, 70 to 93% of them have MB2 canals. So that just shows how important a CBCT can be to help guide you in learning more about their location. So for example, in this image here, this is MB1 and this is MB2. In the second molar here, this is MB1 and MB2. So as a clinician, when you're trying to find MB2, a CBCT can be useful to help you know where you are, where you should go when you're trying to find that MB2. So for example, if I found MB1 here, I know that I need to go lingually and quite a bit distant away from MB1, versus in this situation where they're closer in proximity, I know that if I found MB1, I'm going to go lingually, but not as far off. It's pretty close. So like I said, giving you a better idea of where you are in space. All right, moving forward. So recommendation 6 is interesting because it focuses on how limited field of view CBCT can be useful if clinical exams and 2D intraoral radiographies are inconclusive in the detection of vertical root fractures. So we know that there's certain signs that we can look out for that are suggestive of vertical root fracture, one being an isolated periodontal pocket, another being a J-shaped radiolucency noted on a radiograph. However, I think this image does a great job highlighting how a CBCT can also be used to detect vertical root fractures. So specifically in these images here, we see that there's some obvious sign of some type of fracture going on in these panel here, and in this study it was confirmed after they completed the extraction of that tooth that there was indeed a vertical root fracture. All right, recommendation 7 highlights that CBCT can be used for non-healing or previously endo-treated teeth to determine if further treatment is needed. Furthermore, it can be used to assess overextended obturation, separated instruments, and can localize perforation. So if you come across certain complications, CBCT can help you combat those complications and help you bypass certain things. So in this panel, we see that there's no evidence of perforation. However, here there was a root perforation, and we got more information about what's going on in three-dimensional space through a CBCT. And also in this image, what happened was there was a strip perforation, and again, CBCT gives us more information about the position of that, and hopefully helps us determine how we can bypass some of these complications. All right, this one is super important, and it focuses on the pre-surgical treatment planning phase. And so a CBCT can help to localize apices and also understand the proximity of adjacent anatomical structures. So in this study, what they found actually that there was a perforation in the lingual cortex. Furthermore, in panel D, they found that periapical radiolucency really did extend into the inferior alveolar nerve canal. And this study really focused in on that patient who experienced paresthesia. And so, like I said, being able to take a CBCT ahead of time in this specific sense, pre-surgery, can help manage risks and understand how the whole body relates to one another. Sometimes we focus in on one specific tooth, but we need to understand that there's a lot of other considerations that we need to take, and hopefully translate that to our patient and say, hey, this is what's going on in your mouth. This is a treatment plan that we're thinking. However, there's these certain risks, and that all just ties into informed consent and allowing that patient to make an informed decision that is what's best for the patient, and hopefully minimize that risk. All right, and I think that's a great segue into this slide here, in which CBCT can be used to help with the placement of implants. So these two images are ones that I took of my patient during my residency year, and so during that CBC, this patient wanted anterior maxillary implants, and so we took a CBCT so that we could get a better understanding of the bone density, and in this specific case, we found a mesial defect, mesial to tooth number 11, and like I said, CBCT is not just useful in endodontics. It can be used in so many different aspects of dentistry, whether that be in oral surgery or periodontics. CBCT can really be a great tool. In the 11th recommendation, we see how CBCT can be used for diagnosis and management of dental-alveolar trauma, root fractures, luxation, displacement, and alveolar fractures. And this is super important for all age groups, whether that be pediatric patients. Oftentimes they experience certain types of trauma, falling, root fractures, dental alveolar fractures, We also see this in geriatric patients where oftentimes they might fall and present with different fractures. I did my residency at Harlem Hospital, and CT scans were super useful in understanding more about the complexities of trauma and understanding where certain breaks were and where certain fractures were, and how we could reapproximate some of those bones was very, very helpful. And in the 12th recommendation, we see that localization and differentiation of external and internal resorptive defects can be understood using CBCT. All right. How we can assess outcome is by basically using CBCT to evaluate how the healing has been after surgery and during non-surgical endodontic root treatment as well, endodontic treatment. And they found that in certain situations when there was an abscess of signs and symptoms and a pre-op CBCT was taken, it would be indicated and suggested that a post-op CBCT be taken as well as a means to follow up. So in this specific image, we see that there's a radiolucency in the pulpal canal and also at the apex here, and the CBCT highlights that as well. This is an example of internal root resorption, and we see that in the different sections here, and this is the periapical image that was taken post root canal treatment, and we can see how CBCT can help improve that prognosis and create a better understanding of what's going on. All right, conclusion. So what I want you guys to take away is I'm a huge fan of CBCTs, especially after creating this presentation, because I think it is such a useful tool in both endodontics and in different fields of dentistry as well. And obviously, as healthcare providers, our goal is to improve and provide superior treatment to the general public and to our patients, and hopefully a CBCT is used appropriately and in hopes to improve prognosis, and can be used throughout the treatment planning phases, during diagnosis, between appointments, during complications, for follow-up. It's such a useful tool. And I want to conclude by focusing on two points here that I will link the source of in the next slide. So in one study, they found that an accurate diagnosis was reached in 36 to 40% of cases with intraoral radiographs, compared to 76 to 83% with CBCT. So that's a huge difference. So a CBCT in this particular study helped practitioners reach a more accurate diagnosis, which I think is huge. And in that same study, they found that examiners altered their treatment plan after reviewing the CBCT 56 to 62% of the cases. So after reviewing that CBCT, they actually altered their plan, which I think is incredible. So these are the sources I used, primarily being source number 3, which was the joint position statement. And I want to conclude by saying thank you so much for tuning in. We have the email linked right here, EndoSmilePodcast@gmail.com. If you want to shoot an email or you want to get a discussion going, feel free. I want to thank you so much for making it with me and sticking around to the end. Thank you so much. I wish you and your loved ones all the best, and keep smiling. See you in the next video. Bye.